As you know, high blood pressure is the main reason of global mortality. Not directly, but indirectly, it leads to increased mortality due to stroke, cardiovascular events, etc. And in clinical practice, sometimes physicians ignore to evaluate and interpret the importance of blood pressure fluctuations. Resting blood pressure is weakly related to remodeling or LVH and can only partially explain its development and progression. 5 to 7 METs during exercise reflects the daily hemodynamic changes, and the question is, does exercise blood pressure at 5 to 7 METs reflect blood pressure variability in the ambulatory blood pressure? This level, according to Bruce protocol, is accepted to reflect the hemodynamic load during daily activities. Sometimes, according to especially recent publications in the literature, resting blood pressure evaluations may not be enough to interpret the patient's real situation, because after exercise, hemodynamic load due to volume, pressure, as well as sympathetic overdrive can be changed. If there is no abnormality over the blood pressure fluctuations, effective exercise mitigates the hemodynamic load during daily activities and prevents or attenuates increases in LV mass, or doesn't lead to LV remodeling. How we define exercise hypertension? If we measure greater than mean 200 for men, 210 for women, 190 millimeter mercury, we can accept those patients are associated with exercise hypertension or exaggerated blood pressure response to peak exercise. But at peak exercise, blood pressure measurement is not practical. As I mentioned a little bit before, 5 to 7 METs could be enough to decide the numerical level of blood pressure. What's the clinical significance, and what should we do about it? Of course, this abnormality is directly related to cardiovascular mortality. Dr. Gattiener, I found a chance in Baltimore when I was in Johns Hopkins to see him, meet him, and work with him. Even we worked in different hospitals. He was at University of Maryland in Baltimore. He described the remodeling in these individuals with exaggerated blood pressure. Even those individuals are associated with resting normal level of blood pressure. What happens to those individuals? Daily hemodynamic load is likely the contributor to segmental remodeling. Systolic blood pressure at 5 to 7 METs of exercise reflects the hemodynamic load during daily activities. As I mentioned before, 5 to 7 METs means first or second stages of Bruce protocol could be enough to detect blood pressure numerical levels. Therefore, it is important to detect these individuals with high blood pressure at exercise or stress induction. We described long ago in these patients are associated with not only exaggerated blood pressure response to stress, but increased rate pressure product. In other words, we all know exercise-induced increased heart rate is associated with higher mortality. We checked out almost every single aspect in this group of patients, including tissue dynamics, heart rate response, and blood pressure response. We also detected increased tissue dynamics at peak stress, quantitatively using combined stress induction and tissue Doppler imaging. And these patients are also associated with increased LVOT velocity, both tissue and blood fluid dynamics are increased under stress in this group of patients. Furthermore, the maintenance and progression of remodeling may be mediated by this daily hemodynamic load. According to the previous slides and studies, all sympathetic overdrive effects on tissue, vessels, as well as heart rate reflect the sympathetic overdrive in this group of patients. Thus, attenuating an abnormal rise in blood pressure during daily physical exertion may prevent the development and maintenance of LVH and would decrease the mortality. Therefore, we believe before hypertension treatment in early stage of cardiac patients should be on beta blockage, especially for the patients who have increased heart rate, exaggerated blood pressure, as well as hyperdynamic cardiovascular tissue. Therefore, we believe beta blockage may be a prudent approach to protect against exercise and repetitive elevations in blood pressure. And most importantly, before regular physiologic and effective exercise, we have to make sure there is no blood pressure abnormality after effective medication for that particular patients. Last year, for the first time, we described hemodynamic stress effect on microscopic remodeling and step-by-step cardiac, myocardial segments remodeling progression were documented in this study, and it was started over LV basis and progressed to APEX globally. That's completely consistent with the human hyperintensive remodeling detected by real-time three-dimensional echocardiography. But of course, it was extremely beneficial for our research to document. This is the unique paper showing the segmental remodeling in animal model. We used third-generation microscopic ultrasonography in this precise study at Hopkins to prospectively document the progression of alveolar remodeling. Therefore, after stabilization of blood pressure abnormality, we could advise effective exercise to patients, and we also believe that if blood pressure is stable, exercise is certainly effective and beneficial. However, with Dr. Gattiener, both from Johns Hopkins and University of Maryland, we published in Circulation even large heart study that was supported by British Heart Foundation, and they used high technology MRI, but they forgot to detect blood pressure measurements. That was a quite big mistake for even large studies, because it is almost impossible to say that initial remodeling is a completely physiologic process. We searched those patients, even young generation. Some of them were smoking, some of them the other pathologies. So they should have evaluated according to blood pressure monitoring. And in this particular paper, we criticized that point very strictly. Therefore, we strongly advise, both from my own department in Turkey and UCSF, if you see any individual who have incidentally detected basal-septal hypertrophy or early emerging biomarker, the blood pressure at exercise should be evaluated for those patients for early treatment and prevention in heart failure. And in a very variety of studies, we mention this important point again and again. This is another study from this year, 2022. This is also from European Heart Journal this year. Those mentioned the importance of early remodeling. And I'm presenting my last slide. It's crucial to mention blood pressure fluctuations during exercise in hypertensive patients who are likely to develop LV segmental remodeling and ultimately heart failure if beta and RAS blockages are not performed in a timely fashion as detected. Extremely limited use of medical therapy in onset count study. This is from Mayo Clinic, and they showed very high mortality. But if you look at the medication ratios, those were very low, and it is accepted to rational results. In other words, if you want to evaluate the mortality, First, you should put very effective medication before mortality evaluation. Therefore, we strongly believe that the medical fail in hypertension-mediated heart diseases could be related to practical problems in blood pressure monitoring for hypertensives who face very dangerous daily hemodynamic fluctuations. Thank you very much for your listening.